develop symptoms or confirmed by swabs COVID-19. So we actually had 40 cases that were cases. They either we didn't have access to testing at that time. It was early. Some people just went and isolated. And then there were many people like myself who were a false negative on their first test. And I knew I was false negative because I had the same symptoms as my wife who tested positive. And I went for repeat testing and then tested positive. And then we also did serology as well. And this is looking at the antibody response to the virus. And 86% of the curlers had serology completed. And we found some interesting things there as well, that one of our cases, who was one of the co-authors of the paper, his only symptom was he lost his sense of smell. His wife had more typical COVID, and he just lost his sense of smell. And he actually did not develop antibodies to the virus despite having a positive swab. And we had 4 other cases that by the time we got around to doing the serology months later, the antibodies were already gone. And we had one of my colleagues, friends, who I actually shared the car ride back from Edmonton. He had no symptoms whatsoever, but his serology was positive, and he may have been an asymptomatic case. So we carefully documented everybody's symptoms, and the symptoms of COVID are very non-specific for the most part: runny nose, nasal congestion, cough. And remember, at the time, the World Health Organization was telling us that this was a severe respiratory illness characterized by fever and cough. And fever actually occurred in only 40% of our cases. Loss of sense of smell was very interesting. It was very novel at the time we had our outbreak. It was just something that was being recognized in the media, but there wasn't a lot of publications about it. But 72% of our cohort lost their sense of smell, including my wife, who it took her several months to get a sense of smell back. And one of the things is that, if you're wondering if you have a cold or you have COVID, you can't wait for the loss of sense of smell to tell you that, because that tends to happen a little bit later. As you can see in the bottom right corner there, it came on about 4 days after the onset of other symptoms. So if you're waiting for that to isolate, you're going to spread this to other people. And when we looked at, we definitely had about a third of our curlers had traveled to the US or other parts of the world in February before the Bonspiel. And so we definitely had one person that came back from Las Vegas and was our index case. But when we went back and asked people carefully when their symptoms actually started, there were 10 people that had some kind of mild symptoms during the Bonspiel. And what we know about the incubation period of COVID, it's likely that we had multiple cases enter at once. And then because we were in the bar after the games, eating and drinking together without a mask on, we were spreading that to each other. And we also had transmission in the home. We had 3 curlers who were spouses of other curlers and had a late onset after 14 days. So we had quite a bit of transmission to family members once they took the infection home. So this was probably the most interesting thing. We had a natural experiment in our Bonspiel outbreak, that there was one team that was really paranoid about getting COVID, and they curled and then they left. And they didn't socialize. They didn't come up to the bar for food, the buffet lunches, or eating and drinking together. And other clusters of cases, other super spreader events have really shown that this is something that is frequently the cause of multiple cases and outbreaks, is people being together, not wearing a mask, being in close proximity, less than 2 meters, talking or singing loudly, and that was very interesting that the one case that didn't participate in any of the lunches, any of the social activities, had no cases. So, rather than the sport itself, can't say there wasn't transmission while we were curling, but this team curled the same number of games and didn't have any cases. So that's my experience. So what else has been happening around the world? Well, we know early on when our outbreak was happening, there were about 400 people dying every day from COVID. And most of that was in other parts of the world at that time. It was mainly in Italy. It was starting to be a problem in the United States, in New York. And then, as you see, the pandemic has gone on. And as the second and sometimes third wave started to hit countries more recently, the number of average daily deaths actually peaked close to 15,000 a day. And so now we're upwards of, over 110 million cases and 2.5 million deaths in the world. And hard to believe that 500,000 Americans have died of COVID at this point in time. Now in Canada, our rates are here. So this is, as of last week, we had over 800,000 Canadians that have contracted COVID. 130,000 now Albertans have contracted COVID. And if you look at the right-hand graph, which is the rate by population, you can see that Quebec has been hit the hardest, with Alberta being second on a population basis of number of cases. And as far as deaths go, again, most of the deaths have happened in older adults. That's the population that's been hit the hardest. And as far as rates of death, Quebec was hit the hardest, followed by Manitoba, Ontario, and then Alberta. So what is the outcome? That's the cases and the deaths, but what about hospitalizations, the severe outcomes? And overall, about 4.5% of people in our province who have had COVID have entered hospital. Slightly less than 1% have entered ICU, for a case fatality rate of about 1.4%. So the majority of people will not get sick to the point where they need to be hospitalized from this. Unfortunately, in our cohort, nobody was hospitalized. One of my colleagues went to the emergency room to be assessed, but wasn't admitted. And you can see up here when we hit our peak, and the worry and why we do lockdowns and things is because we were overwhelming our healthcare system in January. And that's where, where we peaked in early January was actually where I volunteered to do COVID work and take care of patients on the COVID ward at the Foothills Hospital, which was not a very fun experience. And takes physicians like myself away from doing what they were trained to do and care for liver patients, when you have to be called in to back up your colleagues and do respiratory medicine, which I hadn't done in 20 years. So what about the variants? So this is a natural thing that happens with any virus. And people have said, the more the virus infects hosts and the more people that are infected with it, the virus is naturally going to mutate over time. This is what viruses do. And it's survival of the fittest. So a virus that emerges that is more transmissible is going to spread to more people, and that eventually will become the dominant strain. And that is what's happened with this B.1.1.7 variant. And this is kind of just a frequency of the different variants over time. And you can see from January of 2020, where the infection was primarily in China, to where it started to spread into Europe. And now in the orange here, you can see worldwide, the UK variant is becoming, accounting for probably 30 to closer to now 50% of cases likely. And there's some pretty scary projections about what's going to happen because of that. So the CDC on the left-hand side of your screen there is tracking the variants, and the variants are the most prevalent in Florida and in California, and why we have travel restrictions and why they're being, starting COVID quarantine hotels for travelers is because this is where Canadians go as they go to Florida and they go to California and sometimes Arizona, and can bring these variant cases back. And certainly we're seeing that. This is numbers again. This was a week ago, but you can go on this website at CTV News is a great one, a dashboard about cases, and they are going up and up. And we've seen an outbreak, and we saw the rapid increase in cases in Newfoundland related to variants recently. So why is this important? Well, they're more transmissible. We know that they're about 50% more transmissible, and what that means is that we could see what happened in places like the UK, like Portugal, like Ireland, like Denmark, where these strains started to take off. And this is actually the percentage in the United Kingdom, and it was a logarithmic growth of back in November, a very small number of cases, just like we have in Alberta right now, small percentage of the overall cases. And from the beginning of the November to the beginning of December, that went to about 30%, and then a month later it went to 60%, and a month later it's almost it's completely the dominant strain in the UK now. And what happened was the case rates rapidly increased because of that, and that's where you get into overwhelming your healthcare system. And it took very strict lockdowns in these countries to bring this back down. So with this variant in our population, it's now transmitting in our communities. We have to be very careful about reopening. Otherwise, we're going to see a third surge, a third wave. That's going to be way worse than what we saw in January. And this is some of the projections that have been, and they're terrifying, right? Because this is the second peak that I was talking about. This is Canadian-based data, and this is kind of the worst case scenario. But if the variants do take off like this, it's gonna require much stronger public health measures, more like what we did in the spring to shut everything down than what we did in December. Okay, what about liver transplantation? So I'm going to present a couple of studies about chronic liver disease and COVID-19. There's a website here which I can put into the chat box and share with you all, or share afterwards. But it's from the AASLD, and it's a living document that kind of updates the most recent information on COVID and liver patients. I was involved with one for the World Health Organization as well, or for the World Gastroenterology Organization. And but this is a very nice document because it's constantly updated. So probably the biggest study looking at, again, came from the United Kingdom, and 17 million patients, 100,000 who had chronic liver disease. And they found that chronic liver disease patients had an increased risk of mortality, about a 60% increased mortality over the general population. And there have been, we know that age is the single biggest risk factor for dying from COVID, but we also know that having diabetes, being obese, having high blood pressure, heart disease, kidney disease, and chronic liver disease all increase your risk. In a large study of out of the US of about 3,000 patients with COVID, they found that patients with cirrhosis were about 4 to 5 times more likely to die than patients without. And in this study, fatty liver disease was the most common cause of the underlying cirrhosis. And as I just said, having a high body mass index or being obese, having high blood pressure, having diabetes, them in themselves are risk factors for having a bad outcome from COVID. But if you have all of those and have fatty liver disease and have cirrhosis, that's an independent risk factor of these other things. And there's been a multi-center study of cirrhosis patients who got COVID compared to age and gender matched patients who just had COVID and to patients age and gender matched with cirrhosis. And what they found was that if you had cirrhosis and you got COVID, you had a higher risk of death than patients who are the same sex and age with COVID alone. But not significantly higher than if you came into hospital with a complication of cirrhosis and you didn't have COVID. We know that being hospitalized with cirrhosis is, a high risk thing, and that's why we do liver transplantation. So that was an interesting finding. And they also found that if you had cirrhosis and you had COVID-19, you had similar respiratory symptoms, similar chest x-ray findings, similar rates of going to the ICU. So there's a little bit of mixed data there. There have been a couple registry studies, international ones. We participate in this one. We have cases. We enter patients' data into these registry studies. And they tend to show that, patients get hospitalized a lot. If you're a liver transplant patient that gets COVID, you tend to go to the ICU about a third of the time, and you have a high mortality rate. But when you actually match for some other factors, liver transplant didn't significantly increase the risk of death. And the problem with these registry studies is clinicians who are entering the data always remember the bad outcomes. We always remember the patients that were the sickest that unfortunately passed away or really struggled going to the intensive care unit, and we're more likely to enter those patients into the registry. So we could be overrepresenting some of the severe outcomes. In a European registry, similar numbers, slightly lower rates for everything. About 2/3 hospitalized, about 15% go to ICU, and 16% died. And again, age is the single most important factor of whether or not you're going to have a bad outcome. This is why we're prioritizing older people for vaccination. So no liver transplant recipients under the age of 60 died. And in a multi-center consortium out of the US, 112 liver transplant patients, again, numbers kind of in between the two previous studies that I mentioned. And they also found independently having diabetes, which we know about a third of our patients post-transplant have diabetes. That was a risk for having worse outcomes. There's one study from Spain, and this was the only study that's been reported so far that actually showed that liver transplant patients who are on immunosuppression probably have a higher risk of getting the infection. We always have told our patients that because of your comorbidities and your immunosuppression, you're likely going to have a worse outcome if you catch it. But this was the first study, and it was age and gender matched, and they showed that if you were a transplant recipient, you're about twice as likely to get COVID. And what they found was that perhaps the one drug that was a little bit worse for catching COVID was Cellcept, or mycophenolate mofetil, which increased your risk of getting a more severe outcome of COVID-19 by about 4 times. Now, we've recently written a letter to our Minister of Health advocating that our liver transplant recipients, for all the things that I've outlined on the previous 2 slides, should be prioritized for the COVID vaccine. And we shared with the minister our data from Alberta in that we've had 17 of the 100 transplant recipients, and this is kidney, heart, lung, and liver, who have acquired COVID-19 have died. So much higher than the general population rate. And right now we're calculating an age and sex as standardized rate for infection and for death in our liver transplant recipients. And so far in Alberta, we've had 30 liver transplant recipients who have had COVID-19, 3 of who have passed away from the COVID. And all 3 of those unfortunate cases were over the age of 65. So what are the recommendations around liver transplantation? And again, from the expert ASLD consensus statement. So if you're a post-transplant patient and you do not have COVID-19, there's no evidence that we should be adjusting your immunosuppression. What we should be emphasizing is the preventative measures. If possible, do not travel, especially now in the age of variants. Okay, work from home if possible. Minimize in-person visits, and this is why, if possible, we'd like to meet with you by telemedicine rather than in person. If you do catch COVID-19, then we may consider lowering the immunosuppression, especially maybe the anti-metabolics, what we call the Cellcept and the azathioprine or Imuran. COVID can lead to kidney problems, and so we have to watch the kidney function carefully. And the other recommendations are we treat COVID just as we would in any other patient. That means if you're an outpatient, there's nothing really that works right now for that. You may have heard things like ivermectin and colchicine. I'm happy to talk about that in the discussion period, but there's no clear evidence that those really help, and they may have some side effects associated with them. If you're sick enough to go into hospital and require oxygen, the one treatment that we know works are steroids, corticosteroids, dexamethasone for up to 10 days. And more recently, there's another drug called tocilizumab, or an IL-6 blocker, which has also been shown to help patients with more severe COVID, especially those, both for dexamethasone and tocilizumab, for patients that are requiring high doses of oxygen or are intubated in the ICU. Okay. I'll let you catch the joke, and I can't hear you laughing. So I'm going to talk a little bit about the public health measures. And one of the biggest things that we can do is avoid being in close contact with others when you're not wearing a mask. So there's a whole lot of data summarized on one slide, but public health measures work, okay? Social distancing, there are studies looking at people who have been in contact less than a meter versus more than a meter. With a known case, there's about an 82% reduction in risk for staying that distance away. And every 2 meters, or every additional meter, essentially every doubling of that, if you go from 1 to 2 meters and 2 meters to 4 meters, you decrease the risk another by half. So we know that social distance, this is an infection that's spread by droplets, large droplets, which can't travel that far. It's aerosolized a bit as well, and that's where being outdoor is better than being indoors for getting COVID. We know that face masks work, and the type of face mask does matter. An N95 mask, like we wear in the hospital when we're around COVID patients, offers a large amount of protection, 96% effective. You have to put it on and take it off properly, and not touch your face after you've contaminated it with your hands. So there's proper ways to do that. Cloth masks and other masks are less effective, but they offer some protection. And we know that droplets can get in through the eyes as well. So there's been interesting studies showing that people that wear glasses get COVID less often. And we're mandated actually in hospital now, not even if we wear glasses, to wear eye protection over top of our glasses, either a face shield or goggles. So this is a really elegant study that came out a little while ago and actually looked at the public health measures on kind of a larger scale, either a country or a large jurisdiction, and what's the impact of limiting gatherings, to less than 1,000, which seems like, wow, that's a lot of people to get together. Less than 100 or less than 10. And remember, like when I got COVID, I told you the public health recommendation was less than 250 people. And we certainly, we never had more than 50 people at a time, probably in the lounge together. So, the fewer the people, the greater the reduction in the R value. And this R value is important. It's published on our Alberta Health website now. And basically what it means is the RT value is, if it's above 1, cases are going to go up. And it's very concerning now that we're reopening and the R value has started to creep above 1 and is definitely above 1 in the north zone right now. And that means cases are going to increase. We really need that to go down. So if our R value is above 1, this is how effective limiting gatherings could drop that R value by 50%. So we could get an R value of 1.2 down to 0.6, and that would rapidly decrease the cases. Closing businesses will have some effects. School closures and university closures will have greater effects. And we know that there's other benefits to keeping kids in schools. So it's a balancing act, but we know when schools are open, there will be transmission, and it will lead to counts going up. We just have to, accept that. And we do know that these work because when we close down, we rapidly drop the curve. And again, when we put modest restrictions into place, the curve was still going up. It wasn't until we really put stricter restrictions into effect in mid-December that we started to see the fall of cases. And now as we ease, I think we're going to start to see cases go up, and with variants, they'll probably go up very high. Okay, the last few minutes I'm just going to spend on the vaccines because this is how we're going to prevent this. So this is what the coronavirus looks like. The spike proteins are important for it attaching to ACE receptors on our cells and it getting into our bodies. And this is the spike protein gene that's been a big part of the vaccine strategy. So there's 2 types of vaccines. There's messenger RNA vaccines and there's adenovirus-based vaccines. These are live attenuated vectors that used to get DNA into the cell, goes into the nucleus, and then spits out RNA, which is turned into the spike proteins. This does not enter the DNA, okay? It comes in as RNA with lipid-coated particles, and then that's transcribed in the cell, not in the nucleus, to make these spike proteins. And then your immune system, when these cells bust open, it picks up these spike particles, presents it to what we call the T helper cell. This is what also causes, what we have to suppress to avoid rejection. And the B cells are the part of the immune system that make the antibodies. So this interaction between the antigen presenting cell, the T helper cell, and the B cell makes these antibodies. So that when you get exposed to the virus after you've been vaccinated, it will mop up the virus. It will also, when infected cells, it will have these, what we call activated killer T cells will come in and get rid of those infected cells. So as I mentioned in our study, some of our curlers had lost their antibodies. Well, we still think that people who have had natural infection and they lose their antibodies, they'll still have these activated killer cells to help with a T cell response to the virus. But the recommendation, and I was lucky enough to have my 2 doses of the vaccine, despite having the virus before, um, to make sure that we'll have immunity. So do they work? Absolutely. The Pfizer BioNTech vaccine is 95% effective. You start to see the curve separate around 2 weeks after the initial dose, but it's really that second dose that's thought to be important to get up to this efficacy rate. The problem with this vaccine is the cold storage. Now they've eased the restrictions for that and say that the virus can be stored at a normal freezer for a couple of weeks. And we like to give these 21 days apart, but my second dose was delayed much longer than that because of vaccine shortages. The Moderna, very similar technology, doesn't have to be stored quite as cold, so that's an advantage. Given 28 days apart, 94% effective. And these are the 2 vaccines, the Pfizer and the Moderna, that we're recommending for our transplant patients because we do not want to give a live virus vaccine like the Oxford AstraZeneca, which uses a chimpanzee adenovirus, or the J&J, which uses this adenovirus 26, which is like a common cold virus, to get that DNA into the cell. But for the general population, these are going to be very important because they're much easier to store. J&J, only a single dose. The Oxford Zeneca vaccine had this interesting phenomenon that they screwed up and they gave half dose to some people on the first shot and then the full dose on the second shot. And they found that was more effective than the people that got both full doses. So kind of an interesting phenomenon. So just to wrap up, what are the recommendations? Again, the AASLD just came out with recommendations around vaccines for patients with liver disease. Sometimes we give people waiting for liver transplant double doses of some of the vaccines, like the Hep B vaccine, for example. That's not recommended for COVID. The antibody testings have no role. So that's a research tool. The serology, like I said, you don't check for antibodies. Even though I had antibodies, my wife didn't have antibodies. We both got vaccinated. Recommend that you wait 14 days between other vaccines. So if you've had the influenza vaccine, we would wait 14 days before giving you the COVID vaccine. And if you've had an infection, we should wait 90 days from the recovery from the infection before getting the vaccine. And the only real severe reactions that have happened so far are allergic reactions. They're very rare. These are very safe vaccines. But one thing that might be of interest to some of this population is polyethylene glycol, which is like PEG interferon. People can cross-react. If you had an allergic reaction to PEG, you can have an allergic reaction to the mRNA vaccines. And if you do have an allergic reaction, which is extremely rare on the first dose, of course, it's not recommended to get the second dose. So this group has recommended that cirrhosis be prioritized for vaccination. We certainly agree with that. People on immunosuppression, including post-transplant patients, should be prioritized. Even if you are scheduled for like a live donor liver transplant, you know that's going to happen. It's not a reason not to get the COVID vaccine. You can't get COVID from the vaccine because it's RNA and it makes that spike protein. That's all it does. It doesn't cause the actual infection. As if you have been recently transplanted, we say that you should probably wait a while before getting the vaccine. Live donors should be vaccinated, and basically all patients who get the vaccine must continue. This isn't a get out of jail free card. We're going to have to continue to wear masks, be socially distant, hand wash until we have enough people vaccinated in the entire population. COVID-19 vaccine is recommended for all solid organ transplant recipients, including those with liver transplants. The mRNA is expected to have a similar kind of efficacy and safety profile, although it hasn't been as well studied in patients who have had transplantation. And generally, we're recommending that we wait until about 3 months after the liver transplant, if you haven't been vaccinated and you're a fresh transplant, until we lower the immunosuppression, because we do think that higher levels of immunosuppression may dampen the response to the vaccine. We know that from other vaccines. So that's kind of the ideal timing for when to give it. But we wouldn't recommend lowering your anti-rejection drugs just to get a better response to the vaccine, because if we get rejection, we're going to have to increase your immunosuppression, and that's counterproductive. And of course, I think a lot of people here will be interested in this as well. People who are around transplant patients, their caregivers or loved ones, we are advocating that those family members get vaccinated as soon as possible as well. So how are we doing as far as vaccines in Canada? Well, this is, again, from a week ago. You got to look way down on the list to find Canada. I think it was 55th on this list when I counted. We're starting to get more vaccines now, but we've got a long way to go. We've only vaccinated 3.5% of our population compared to Israel at 3/4 of their population. So again, as of last week, 160,000 doses, 62,000 Albertans have had 2 doses, which makes them fully vaccinated, which is a very small part of our population. But the vaccine rollout is continuing. We heard about all the problems that crashing the system happened earlier in this week, but this is the phased approach to how things are going to roll out in phase 2 after our oldest population and all of our healthcare workers and our those in assisted living have been vaccinated. You'll see that people with specific conditions are in group B of phase 2. So we're thinking that liver transplant recipients would fall into this phase likely. So it'll probably not be April, but maybe May. And of course, if you're eligible by your age category, that may get you in sooner. So I'll stop there. I know that was a lot of information, but I learned a lot preparing the talk and from my own experiences with COVID. So I hope you found that helpful.
Thank you, Dr. Burak. Wow, I learned a ton. I can't thank you enough. Would you like to field some questions?
For sure. Let me just open up the chat here. Are level 3 masks an additional benefit to cloth masks? Linda is asking. I'm not sure exactly what you're referring to as level 3, but we definitely the N95 masks have the most protection. And you know what, I think if we had enough of a supply of N95 masks, that's what everybody should be wearing. But there have been supply chain issues with N95s. Surgical masks would probably be the next best thing. It's important that they fit well. It's really important how you put on and take off masks. There's been some, Fauci and others have talked about double masking, and so wearing like a surgical mask and a cloth mask, so surgical mask and then a cloth mask over top of that, maybe some additional benefit. But it's also about, when you have to take that off, who you're around. So if you're, putting that mask on where you're outside, probably less effective, but then you go into somebody's house and, you take it off and you're with other people and you don't know if they're asymptomatic. Yeah, that's we take our masks off to eat and drink, right? So restaurants and bars, and exercising with a mask or two masks is not a fun thing to do. So like the three most risky things, there's lots of great data coming out now. The three most risky things are restaurants and bars, and gymnasiums, and those are going to be high risk activities. Um, Droplets versus aerosols. Yeah, so that's a great question, and I think uh, there's been mixed messages around this, and there's people in two camps around whether this is predominantly droplets or how big of a component aerosolized spray is. And it's clear that there is some transmission from droplets. Some of that will land on materials like your cell phone, tables. We wondered about our outbreak at the Bonspiel, whether it was sharing the communal spoons at the buffet line was one mode of transmission. Those types of transmission, which we call fomites, are thought to be important but not hugely important. And maybe that's led to an overemphasis on sanitizing surfaces and sanitizing things, rather than some of the emerging data around the finer droplets, which are more aerosolized and spread further in the air. So we clearly know that from super spreader events like our own and others, that being indoors is much riskier than being outdoors. So so there probably is something to that aerosolized spread. And there was this 15-minute rule created, that if you're within 2 meters of somebody without a mask, it needed to be 15 minutes or more. And that led to even, some of our staff in the hospitals where we wear, an N95, but then we go and have coffee with someone. We would take our masks, have coffee with someone, but we would do that for 14 minutes and that would be okay. But there was some really interesting data out of the NFL study, where all the athletes were wearing, where they were tracking how long people were actually in contact with other, and cell phone data and things. There's some really brilliant stuff that's coming out around that. Is that maybe the time that you need to be in contact with somebody is much less than we think, and it's probably going to be a lot less with the variants. So yeah, it's an interesting question around aerosolized versus droplets, and I will I'll try and get you a good reference on that. Linda, another question around how will higher risk patients be identified for earlier vaccines? So that's a really good question, how we're going to prioritize patients in that B category. And I think they have said they want to make the decisions around risk and data. It's clear from our data in Alberta and other places that our Indigenous population has higher rates of hospitalization and worse outcomes at younger ages than, and that's why there's an age difference for that particular population. And I hope that they will apply the same kind of rigor around what we know about risk factors, including what I shared around chronic liver disease, immunosuppression, having diabetes. It does get complicated if we have, too many categories. But, I would hope that they may entertain a strategy in that 2B of prioritizing the highest risk patients first. John has asked, what happens if a person living with a live donor transplant recipient receives a live virus vaccine? Probably not much. The 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 risk of getting, you know, an active infection for somebody who has a competent immune system is probably very, very, very low. We just caution people about getting live vaccines when they are immunosuppressed themselves. So the vector itself is quite quickly eliminated by the body. It gets the DNA into the cells, and then the immune system takes care of it. So it's unlikely that that would transmit to a liver transplant recipient. But it's a good question. I haven't seen any specific recommendations around. We are recommending the mRNA vaccine for our transplant recipients or immunosuppressed patients, but I haven't seen any specific recommendations about family members. So I believe it would be okay to receive the live virus vaccine, but more and more data will come out on these types of issues. So I'll try and find an answer for you, John. Anyone else? There's the link to the Bonspiel paper if you want to read it. And I can make my slides available to everybody as well. I'll have the references. So.
Perfect. Oh, is that one more I see?
So RC, RN had the Pfizer vaccine. I was asked repeatedly if I was immunosuppressed, but he said either vaccine is okay. Yeah, either of the Pfizer or the Moderna vaccine is okay for an immunosuppressed patient. They're very similar. That the technology is the same. They're both mRNA vaccines. The only difference between Pfizer and Moderna essentially is the Pfizer vaccine requires colder temperature storage. And so that's why preferentially when we had short vaccine supplies, most of the healthcare workers working in urban centers were getting Pfizer, and the Moderna vaccines were being shipped preferentially to some more remote areas, including the north part of Canada. So, but yeah, for anyone immunosuppressed, either the Pfizer or Moderna vaccine, which are mRNA based. And as these other vaccines become available, they're going to be fine for the patients who are not immunosuppressed.
Are there any more questions? Okay, well, if not, I'm going to thank all of you once again for joining, and thank Dr. Burak. That was really great information. I hope it helped a lot. Watch for our next Living with Liver Disease session on April 29th with Dr. Michael Houghton on the hepatitis C vaccine. And I want to also invite you all to hop on to your Facebook and look up the Alberta region of the Canadian Liver Foundation. We have a new page. If you can hop on there and give us a like, we're going to post the link to this recording on March 1st, as well as all the future sessions. So that way you can stay informed on all the upcoming events from your Alberta chapter. So I will say adieu and thank you all and have a great night.
Thank you, everybody. Stay safe. Wear a mask.